Well, thanks for allowing me to come and speak with you today and inviting me. It's very humbling to get to speak to your peers and people who you trust and respect a lot and admire. Complete versus finished, there's been a lot of debate in the English language about what these words mean. Dictionaries have a hard time defining them. Now, the story I've heard goes something like this. There was a competition, it was a linguistics competition, and it was held in London in England. And this Guyanese man, although he sounds a lot like a Jamaican, but the story is that it's Guyanese. They asked him at the very end of the competition, they said something like, so sir, what is the difference between complete and finished? Can you explain it in a way that people would understand? He paused for a minute, he looked at them, then he very astutely said, if you marry the right woman, you are complete. If you marry the wrong woman, you are finished. If the right woman catches you with the wrong woman, you're completely finished. We're going to talk about some things that are fun, but some things that take a lot of effort as well this morning. A lot of us feel like we're walking uphill at times with the ACGME requirements, trying to reach them. The recent accreditation changes have really changed the expectations of what we need to do as teachers and what our residents need to accomplish in residency. So oftentimes we feel like we're just walking uphill, and the necessary skill set of what it takes to be a successful, effective, excellent family physician who's a teacher has really changed. We're being asked to move from being clinical educators to being clinician educators. We're asked to move from small e educators to big E educators. What does that mean? The knowledge, attitudes, and skill sets required to be an excellent teacher have changed. It used to be that you would just go out and you would see a lot of patients, you'd develop your clinical skills. One day you'd come back and you would impart that knowledge to the residents and tell them they're doing a good job and then demonstrate for them what it means to be a good clinician. With all the changes that are happening now, we're being asked to be experts in education, experts in evaluation, experts in feedback, and experts in assessment as well. So those are some of the ways that we're asked to be big E educators. So we started out with these competencies, assessing that a graduate is a graduate is competent. And if they're not competent, then they're finished, I guess. But that they're competent in these 6 areas means that he or she has been able to satisfactorily demonstrate competence in 22 sub-competencies. And along the way, have done enough to convince the faculty that they're capable and competent in 230 milestones. They started us out with 6. It was kind of a little bit of a bait and switch. Then they moved to 22. We thought, 22, I got these. And then they said, 230. However, let me encourage you, because since we're really not responsible for teaching level 5, there are only 194 milestones. And so this means that we're responsible for feedback. It requires us to provide and collect and analyze lots of relevant, high-quality feedback. So let's talk a little bit more about that this morning. If we're going to do that, we have to know ourselves, we have to know our learners, and we have to explore our learners and better ourselves. But we need to know ourselves better. We need to know our learners better. We need to explore our learners better. You're worried about this one because that would be terrible, but we need to better ourselves more. So we need to become more better. At this point, I'd like you to look in your tables. Still don't touch the apples. You're very good at following directions. This is fantastic. This is better than being like kindergartners would have a hard time, but this is good. There's a sheet of paper there that has 7 questions. I would like you to look at those 7 questions carefully. Think about your feedback experiences that you had in training. Does recalling feedback you received while in training result in any of the following? And just read those, take about a few seconds or about a minute, and circle the ones that apply for you. Okay, I have about 50% of the ayes, so I'm going to go with that. We'll kind of work towards what the average would be. If you didn't circle any of those, I'm very happy for you. That's great, and you're very fortunate. If you circled 1 or 2 of those, you've had some experiences that you remember that aren't so good. If you circle 3 or 4 or 5, you might just have feedback PTSD. If you circled 6 or 7, when you go home, I'd like you to seek counseling. Sometimes our negative experiences can really hamper our ability to deliver effective feedback to learners because it keeps us from being willing to engage them, or we have a lot of doubts or worries or fears. And so part of knowing ourselves will help us to provide better feedback. And we're not in this alone. We have very similar things that happen to us. And so I'd like you to look to the person next to you and kind of work in groups of 2 and take 1 minute and have the first person share with their partner just one of the stories that happened to you that weren't very positive that you can recall about giving feedback that you received, I should say. If you did not have a negative experience receiving feedback, use this minute to talk about things that concern you about you giving feedback. So take a minute and do that. The first person will do this for a minute, and then you'll switch roles, so each person will get an opportunity to speak. So take a minute to do that. Okay, if you're speaking, you should wind up what you're saying and switch over to someone else at the table speaking. So I would encourage you to think about doing this exercise with your faculty when you get back. I did this exercise with our faculty and a faculty member who is a master teacher. I've learned so many things from him over the years. He could vividly recall an experience that he had as an intern, and this was for him 30 plus years ago. So we're knowing ourselves a little bit better to help us understand how to give better feedback. Another challenge in feedback is misunderstanding. There's oftentimes a misunderstanding of our learners, who they are, and what they want. And there's a misunderstanding about what feedback actually is. So we're going to explore that a little bit. By and large, our learners are millennials, born during this time frame here. They have significant experiences during their formative years, 9/11, Columbine, Oklahoma City. They're very optimistic and self-assured, which has a lot to do with how they were raised by us, by you guys, their parents and grandparents. They're heavily marketed to. They really like hip-hop a lot. Or hip-hop became very popular cross-culturally during the era of the millennials. They're really big into smartphones, and they've actually infected us with that virus as well. I can see that from here. And there's a sense of really seeking collaboration. This is Ronda Rousey. This is also Ronda Rousey. So she's a gold medal judo winner who's become the #1 pound-for-pound fighter in the world in mixed martial arts. So what is she doing on this slide? I think she doesn't represent all millennials. She doesn't represent all millennials any more than the average in a study represents all patients. Averages tell us about groups, individuals tell us about individuals. But, she represents some things about millennials in that they have different acceptances and different expectations than prior generations before them. And she also represents that she's able to be a protagonist in an action movie with men and was fully accepted in that role and seen as a physical equal to the men and just as an equal to them in many ways. She also represents the added pressure sometimes that millennials can feel to be everything to everyone, that you have to have the perfect physical traits. You have to be perfectly fit. You have to be perfectly good with your family, to be perfectly good on the job, perfectly good with your friends. So that's something we should keep in mind when we're giving feedback. In a minute, you're going to see a few film clips from a movie called The Expendables. In The Expendables 3, Sylvester Stallone's character is worried that his longtime team of guys who go out and do good and shoot people and save the world, that they're getting too old. He's worried that they'll actually be hurt. So he goes out and he recruits a young group of people. He recruits a group of millennials to go out and do this with him. In this series of 3 clips that you'll see, I want you to think about what you're seeing in his interaction with them and think about your learners as well. I hope you saw some traits of your learners there. They wanted to contribute. They had a lot of questions. They didn't just take orders. He said, I've got some things I want to ask you. I want to know a little bit more about you. I want to be known a little bit more by you. Technology was just something that was expected to be used. They didn't want to go in Rambo style and just shoot everybody up. They said, let's use some technology so we don't have to do all that. Let's make our lives a little bit easier. Just kind of expected. They naturally worked together as a team, deferring different parts of the assignment to each other, playing to each other's strengths. They had a little bit definition of family. A lot of millennials have experienced and have grown accustomed to different types of families, often elevating friends to the level of family. They're very confident. They wanted to help and show their skills. While he's their leader and they're going to follow him, they don't stand in awe of him. They're willing to ask questions. They want to contribute. They want to actually collaborate. So these are some interesting things that we keep in mind when we're providing feedback. We have to know who our learners are. They're very interested in work-life balance. Live to work was more the traditional approach to life, and then the boomers were big into that. And then the Gen X folks came along and talked about working to live, and now we have the millennials who talk a lot about working and living, looking more at not work-life balance, but more of a work-life blend with family, career, health, friends, that sort of thing. So let me put it this way, generations and physician identity. Physician is my identity. I am a physician. That's a more traditionalist approach. I identify myself as a physician. A physician is what I do. That falls along the line of more baby boomers approach. Being a physician is only part of my identity. That would be probably more of a Gen X vision. How do I balance who I am with being a physician? That would be more of a millennial position. So hopefully that gives you a little bit more insight into the learners that you're providing feedback for and who we work with every day. This is on your handout. There's another piece of paper on your table. And I just want to bring it to, you can look at the whole handout at your leisure when I'm not talking, hopefully. But you can, I wanted to highlight the millennial column here. And really the one about routine feedback. All those times you took them for coaching and the coach never said you're doing anything wrong. They said, way to run, way to swing that bat, good job. That was formative. So receiving feedback about what they're doing is just a natural part of life. That's just how things are. It's just a natural expectation. Got trophies for performance, for showing up and doing things. Extra time has always been provided for testing and those sorts of things. So getting feedback and getting extra help is just how life has always been, and that's just fine. So hopefully we've talked so far about one misunderstanding. We understand our learners a little bit better, who they are and what they want. We know that they're millennials, and we know that they want feedback. So what is feedback? This is feedback. This is the greatest feedback device right now. It gets you from point A to point B, and that's what feedback is. Feedback is getting from point A to point B. And notice the little thing says, hey, 15 miles, stay on this road, keep going, you're getting there, you're about 2 miles there, turn right, okay, hey, you turned left, let's course correct, why don't you go up here and take a right? That's what the GPS does, and that's the type of feedback our learners need to get from us. We're reminding them of when they're doing the right things, and as they go off track, we try to bring them back on track. So when you think about feedback, think about the GPS. Effective feedback. This is on your table as well, because my goodness, this is a lot of stuff for a slide. There's too much stuff on here. It's to remind you that the nuts and bolts of feedback are pretty complex, and there's a lot of things to learn. We're not going to do all these. I'm going to distill this down to 7 things for you. So if high-quality, effective feedback is kind, it's useful, it's about changeable behavior, it's clear, it's specific, it's non-judgmental, it's honest, and it's timely. If you can deliver feedback that way, you'll be great at delivering feedback. And by non-judgmental, I don't mean we don't tell them what they're doing incorrectly or tell them how to do something better. We don't say you're a bad resident. We might say you have done something not as well as you could, or you've done something not to the target that you're shooting for. If we are not willing to tell residents and our learners when they're off track and how to get better, so not just when they're off track, but how to get better, and we're not willing to tell them how to do what they're doing better, they're not going to value the feedback we give them. So while it's important to acknowledge the things that they're doing well and start there, if that's all that we do, we're not going to be really giving them what they want and what they need. Okay, so we got it down from a slide of a bunch of words to a slide of 7 things, 7 traits. I'm going to define feedback for you in 5 words here. On your paper are 5 blanks. You can take out a pen and you can write it down, or you can just remember it. Feedback is really just 5 words. Feedback is informed, objective appraisal of performance. It's not fancy, it's just informed, objective appraisal of performance. It's not filled with emotion, it's just informed, objective appraisal of performance. The only emotion it might be filled with is our deep desire for them to be as good as they can possibly be. And our method of delivering that informed, objective appraisal of performance is we do it by way of reflective discussion. So 2 words that would describe feedback would be reflective discussion. So why do we bother giving all this feedback anyway? We give it because we want to catch them doing something good. We say, oh, that was a good job, but what does that mean? When we tell them what they did that made that a good job, that allows them to do that same thing over and over again. That's how you become better. And we help them course correct. The best golfer in the world, Tiger Woods, has always had a coach. Can any of those coaches actually beat Tiger Woods in golf? No. But he has always had a coach, and what does the coach do? The coach does all of those things. The coach says, hey, you're doing this right. Hey, you know what? You might not have noticed this, but your hip's coming through a little too fast or too slow. So that's what our learners need. The same thing like great players need coaches. Learners need coaches and feedback as well. So we talked about our learners, that they're millennials. We talked about what they want, feedback, and we've talked about what feedback is. The other challenge is everything else, CT3, comfort, time, training, and tools. Now, there are lots of reasons for us to look at comfort, time, training, and tools, but I just wanted to say a couple of things about them before we move on. We're not going to talk about tools, we're not going to talk about time. I'm just going to hit a couple of areas of training and remind you that some of the comfort issues we've already discussed, because past experiences that you already talked about sometimes affect our comfort. But oftentimes we can be fearful that our feedback might mess them up. We might feel exposed because we're talking about things that we might have messed up ourselves when we were residents, so there might be a sense of hypocrisy. That's okay. That actually is honest. Just say, hey, I remember when I was a resident, or maybe don't start like that, because then they're like, oh, they're going to tell us a story. Or you could just say, I remember when I did that. I messed that up too, and this is what I did to get better. Or that patient was yelling at me, and I got really frustrated with them, and I yelled back at them. I wasn't able to use my frontal cortex to check my amygdala. Reflecting back on your own experiences can be very helpful for them. 3 destroyers of effective feedback are lack of clarity, unrecognized biases, and the lack of trust. Clarity and destination, that's actually been fixed, right? Because the ACGME has given us 230 destination points, so we can take that one off the shelf. We've got plenty of guidance for that. 10 years ago, we might not have been sure what the destination was, but we have some better guidance now. There are three types of bias that I want us to pay attention to. One is the halo effect, where a resident is good in many things, or good in a couple of areas that we really like, and we overlook everything else. Or they're great at communicating, or they're really great at professionalism, and we allow that to skew and miss the fact that they're struggling in PBLI or struggling with medical knowledge. Or oftentimes what happens is we take the resident who's crushing the in-training exam score and we stop paying attention to the other 5 competencies. Remember, you have to be competent in 6 out of 6 to graduate, not 5 out of 6, not 4 out of 6, but 6 out of 6. The other thing is the horn effect, where a resident we've had a bad experience with them and we never let them get over it. Mentally, we can't forget that they did something bad in July of their intern year, and we're just totally colored for the rest of their time. We have to be mentally disciplined to realize that they can do things that are still good, and that one experience shouldn't dominate how we think of them. There's a central tendency bias where there are some of our faculty who just believe everybody's average. Well, if they could ever be as good as me, then maybe I'll give them a 4, but everyone else is just going to be a 3. So be aware of how you fill out those forms. And then the leniency-stringency bias. The leniency bias is the person who sees a score of a scale of 1 to 5, and everyone starts at a 5. And you can lose a few points here and there. Maybe you get down to a 4.5 or a 4. The stringency bias, they see a scale of 1 to 5, and everyone starts at a 1. And they work hard, and they claw their way up, and maybe they'll get a 3. So we have to be careful and be aware of what our bias is when we fill these things out so that we can do a better job at providing even feedback to all of the residents. And the last significant thing is trust. If our residents can't trust us, then they're not going to listen to us. If your patients don't trust you, they're not going to listen to you. Residents have to know that we will keep our promises to them, that we will always act with honesty and integrity. They need to know that we will speak the truth and give them corrections in love and in kindness. They know that we will meet our obligations to them, that we will look for others' interests, their interest, as highly as we look out for our own interests. They need to know that we'll be reliable. I think if we've got the trust part right, they'll overlook a lot of other things. Apple time. At your table, you've got some apples. When we're done with this exercise, not yet. When we're done with this exercise, please eat them because they cost a fortune. I want you to, at your table, that same person you talk to, I want you to look at that apple, don't touch it, don't pick it up, and I want you to tell them how that apple tastes. 15 seconds, I want you to tell the person at your table how that apple tastes. You can't touch it, but you need to tell them how it tastes, to describe it as best you can. Okay, now, someone at your group or in your table who likes apples, who's not allergic to apples. The apples are clean, I've been promised. Pick up the apple, take a bite out of the apple. Make it a small bite, please. I don't want to have to do a Heimlich maneuver. Just take a small bite, chew it up. Okay, now that you've taken a bite of that apple, turn to the person at your table and tell them what that apple tastes like now. My guess is that you were much better able to describe that apple after you tasted it. You could tell them things like, You couldn't tell them what you expected it to taste like. You might look at that apple and go, well, I've experienced an apple like this before, and it probably tastes like this. You can actually say this apple is crunchy, or it's mealy, it's sweet, or it's juicy, it's tart. You can actually use meaningful words to describe that apple. You don't have to guess at what it tastes like. I want you to think about that as we look at this next video that's coming up. This is a second-year resident in good standing. This is a core faculty preceptor in good standing. The resident comes to him and says, I have a case. And she says, I saw this young kid's got otitis media, fever and pain for more than 48 hours. I gave them some amoxicillin, it's weight-based. I realized he has some extra history of these otitis media infections, so I used some of that motivational interviewing stuff that we heard about in a lecture and talked to him and found out that the mom is kind of pre-contemplative, but she might think about this at another time. And you'd say, wow, that's pretty good. Check, check, check. You did a fine job. You gave them some good feedback using the wheel that we talked about. You gave them some informed, objective appraisal of the performance that she just did. That happens a lot, right? Well, let's see what happens in the room if we went in to direct observe what's going on. So we'll watch this video together.
Okay, so I wrote a prescription for an antibiotic for Aiden that should help with the ear infection, but in looking through the chart, it seems like he's had 6 or 7 of these just in the past year or so.
Yeah.
That's really a big problem.
Yeah, it's pretty stressful for both of us. I think it's really upset.
Well, one of the primary risk factors for multiple ear infections in kids is actually smoke exposure. Are you smoking?
Yeah, I do smoke, but I don't smoke around him. I try really hard not to smoke around him.
Well, the fact that he's having these ear infections is indicating to me that he is being exposed to smoke. And so what can you tell me about that?
I don't know. I try really hard not to smoke around him. I don't smoke in the car. When he's home, I go outside to smoke. I know it's bad, and I know it's bad for him, so I don't want him to be around it, so I try really hard.
I really need you to quit smoking, both for your health and for Aiden. Did you know smoking around your child is associated not only with ear infections, it could get to the point where you have to put tubes in his ears pretty shortly here, but also things like vitamin C deficiency, cavities, like dental cavities, behavior problems, asthma, other upper respiratory infections. It's really putting him at a lot of risk. In addition to that, kids of smokers end up smoking themselves. Do you want him to grow up to be a smoker?
No, but I don't smoke. I've thought about quitting, but it's really hard, so I just don't know how to do it.
Well, now's the time to quit. It's really gotten to the point where you can't keep smoking. Not only for him, like I said, but also for you. You're putting yourself at risk for lung cancer, for emphysema, for oral cancers, for heart disease, for all kinds of things.
I know. I've heard, people have told me before, I've heard all that. I just don't know how to do it. How am I supposed to quit? It's so hard.
Well, there's all kinds of things you can use now. It's not as hard as it used to be. You can use nicotine replacement. There's patches, there's lozenges, there's gum, there's the inhaler, there's nasal spray. We can talk about medications. You can try Chantix, you can try Zyban. There's quit smoking groups you can go to. There's hotlines you can call.
I just don't have time
There's
for
no
any of
reason
that.
why you shouldn't be able to quit. This is really important.
I understand that. I know it is. Everybody has problems, right? It's really, really hard.
Well, what can be more important to you than the health of your child?
I don't know.
I really need you to tell me that you're going to quit smoking. This is really important.
I'll go look at all those things and I'll try to find something and I'll talk to my doctor about it.
Okay, well, I think you really need to think about this seriously. Like I said, it's really putting yourself and your child in danger.
Okay. Whatever. Okay.
Okay.
It's quite amazing the difference between what happens in the room and what is told to the preceptor. We laugh. We don't know that hasn't happened. You don't know no idea what goes on in that room unless you've gone in to watch. The interesting thing is that when you think about how the resident presented the case, she didn't tell us anything that wasn't true. Everything she presented to the preceptor was true. Even the motivational interviewing part, because that's what she thinks motivational interviewing is. But how would we know that? The preceptor at the table, this resident is getting high scores on their evaluation form. Unless you go in the room, you really don't have an idea of what's going on with the resident. So she told no lies, but yet there's obviously some points at which course correction could occur. There were a few things that went well. Documented observations with feedback is the sine qua non of competence-based education and milestone assessment. If we are not watching our residents take care of patients, there's no possible way that we can sign off that they're competent for graduation based on those milestones. Not a chance. If we look at the high-level words that they use and Bloom's taxonomy there in the milestones, the only way for us to say that this resident meets those criteria is to do some direct observation. Direct observation allows us to cover all of the competency areas and provide better formative feedback to our residents. So the importance of direct observation, it provides insight into communication skills. Communication skills can only be assessed by watching. It allows us to see their physical examination techniques. It allows us a better assessment of their competence overall. We can reinforce their desired behaviors. It allows us to correct errors, all in real time. The other cool thing about direct observation, and this is really cool, is the joy that it brings. It makes us feel more like teachers. It makes us happier that we're teaching. We're not just filling out check boxes. Some of that joy that the EHR is just stealing from you, sucking the life out of you. Get away from that computer screen and walk away from the precepting table and walk into the room where the resident is and watch them do something. You'll be so happy most of the time. You'll be like, they really get it. They're really good at this. This is awesome. And you'll know exactly what to tell them that they're doing that's so awesome. Because most of the times, they're doing a really good job. But then there are times where we'll be able to help them course correct. We'll remember those patients. We'll feel like that patient is our patient too. It brings a lot of joy, and it makes the resident feel that you're really in it with them as well. You're not just hovering to check off and see if they do the right things, but you're in there. Osler said, there's no more difficult art to acquire than the art of observation. And for some, it is quite as difficult to record an observation in brief and plain language. A quick note on observation for interprofessional care. It doesn't have to be physicians who do this. Behavioral scientists do a great job. PharmDs do a great job. Social workers do a great job. Peers do a great job. Knowing is not enough. We must apply. So now is your chance for some application. On the table, right below where the word feedback is defined and described, you'll see something that says plan on it. When I go home, I plan to, I'm going to give you a minute. It starts 15 seconds ago, apparently, to write down what you're going to do when you get home based on what you heard in this talk this morning. Something that you're going to do, 2 things that you're going to do differently or do better or do more of because of this talk. Take a minute to do that, or 26 seconds. Okay, so either take these 2 sheets of paper with you home, or take out your phone, take a picture of them, or you can stop in the lobby. They will frame them, and you can hang them in the office to remind you of what you want to do. If you did not write, everybody should have 2 things, but if you didn't write down that you're going to practice, then you have a 3rd thing to do, right? So if you didn't write down the word practice as part of your plan, write that down, and now you have 3 things to do. Practice comes in the form of faculty development. You could have a lecture or a session on learners and their needs, a session on generational differences. You could have a session on faculty experiences like we did with the PTSD. or expectations around feedback. You now have a session on bias where you break down all the terms and how to avoid them and how to overcome them. But the key really is practice, practice, practice. Watch some videos together, debrief them together, role play together, discuss things together. These will help you to decrease the variance between the evaluators. You'll still be different because everyone has their own personality, but you'll start to have a similar vocabulary and a similar approach to providing feedback and assessment. It helps you develop a more common language. It helps faculty understand each other better, where they're coming from, how they see the residents. That kind of reflective discussion amongst your faculty will help you become a better faculty as well as better assessors and evaluators. So in closing, you now know how to know your learners better. We now know how to know ourselves better. We know how to explore our learners better. That's direct observation. And we've had some time to think about how we can better ourselves more and make ourselves more better. I'd like to thank you for your attention and for being here. I look forward to seeing you in Minnesota. These are a bunch of people that have helped me along my career path and got me to this point. And special shout out to Mirul Patel and Chris Durgan, who somehow managed to take copyright protected video. I shouldn't have said that. They managed to help get that video presentable for you here today. I had to collaborate with my millennial colleagues in the fellowship. Thank you very much for being here.